All right, good afternoon, everybody. My name is Sagger Mawri. I'm a cardiology fellow at Henry Ford Hospital, and we're just going to go through a case of caval valve implant for the treatment of severe tricuspid regurgitation. So this was the case of an 83-year-old man who had history of severe tricuspid regurgitation that had been managed medically on maximal diuretic therapy, and because of worsening right-sided failure, he was referred to the Center for Structural Heart Disease at our institution, and he was being evaluated for percutaneous options. So he's had 6 months history of progressive right-sided heart failure, including severe fatigue, dyspnea on exertion, abdominal swelling, lower extremity edema, and all of this despite escalating doses of diuretic therapy with Bumex. Past medical history included hypertension, type 2 diabetes, peripheral artery disease, prior bypass surgery 3 years before, a pacemaker for sick sinus syndrome, and mild AS. I've alluded to the surgical history, family history, non-contributories. He was a former smoker, and he was on the medications listed here. So a 2D echocardiogram showed preserved EF, but showed elevated systolic PA pressure and severe TR with systolic flow reversal in the hepatic veins. Right heart cath had been done, which demonstrated the following pressures. And so there was thought that this severe TR was likely because of plastering of the septal leaflet of the tricuspid valve by the pacemaker that had been placed 3 years prior. This is echocardiogram. We can see the TR. So he was being evaluated initially by CTS and was turned down because of prohibitive surgical risk, which is often the case in somebody his age and with his comorbidities. And so a decision at this point was made to proceed with caval valve implantation. So to begin the planning for this procedure, a CT chest with contrast CAVI protocol was done. And so the plan was to have it as an elective procedure. However, he had to be rehospitalized with NYHA class 3 to 4 heart failure. And so during his readmission, structural heart disease team were consulted. So this is the CT CAVI protocol that was done, and it was done to try to establish dimension measurements of the RA and IVC junction where the caval valve will be implanted. And in his case, he had a dilated RA-IVC junction of 28.9 by 34 millimeter. So when he presented, he was already on signs of volume overload essentially on exam. He had the pansystolic murmur, elevated JVD, pitting edema. And so the procedure, he was taken to the cath lab for CAVI, baseline hemodynamics were obtained, and the procedure was done through right IJ and right femoral vein approach. So let's see. The pigtail was put in just to establish the landmarks and do an angiogram. And IVUS was used to reconfirm the measurements. Here you can see the diameter being 33.7 millimeter in size. And therefore it exceeds the size of the valve that would be used, which is the 29 millimeter Edwards-Sapien valve. So at this point, a 400 centimeter Nitrix wire was advanced via the right femoral vein into the SVC, and it was snared from the right IJ and externalized. And at this point, the sheath, the femoral sheath, was exchanged for 16 French Cook sheath for delivery of the Cook Z stents, which we see here. So initially when they placed the first Z stent, they noticed that it actually migrated upward. This was a 35 millimeter Z stent. And so to prevent that from happening again, they used a reliant balloon from the right IJ into that junction under IVUS guidance to prevent migration of these Z stents as they worked to downsize the lumen of the RA IVC junction. So here we see the additional Z stents being placed. And this is really to downsize the junction and to create a landing zone for the valve. Okay. At this point, the inferior aspect of the Z stent was snared to prohibit the valve from migrating with implantation. And we're going to see the final diameter on IVUS. So they were able to essentially narrow it down to 27 millimeters, which was thought to be sufficient for the valve to be implanted. Let's go forward. So after this was done, the sites were perclosed. Echocardiogram confirmed intact function without perivalvular leak, and there was still some residual TR, but he was discharged 2 days later in stable condition. So some of the, we've done a couple of these procedures now, and the other procedure that is being done to treat severe TR is actually using the mitral clip. We've done a couple of those cases as well. But some of the teaching points from this particular case is that you may need to place these Z stents, as many as needed, in order to narrow down and downsize that lumen to be able to deploy the valve. In this case, a total of 4 Z stents were used. IVUS was very important. It was used to confirm the downsizing. And externalization of the guide wire through the right IJ was helpful in creating a rail for the Z stents and for valve delivery. And the balloon use to prevent migration was also helpful in this case. And so just a little bit about severe TR. We know it's associated with high morbidity and mortality, and it remains overall an undertreated condition. The pathophysiology involves reversal of the blood flow from the IVC that contributes to progressive worsening right-sided failure and congestive hepatopathy, and affecting the portal and mesenteric circulation. Surgery remains, the gold standard. However, in these folks who are elderly and with lots of comorbidities, they're oftentimes at inoperable risk. So there are various percutaneous interventions that are coming about for treatment of severe TR. Again, the mitral clip and the Metroline systems, and so you'll be seeing them in the near future. CAVI is also emerging as an alternative procedure. CAVI was first proposed by Dr. Davis and his colleagues a while ago in animal models of severe TR, and were able to show that there were immediate improvements in hemodynamics. And Loudon and colleagues were able to then perform the first in men experience about a year later. And initially they used a valve that was custom made and had both an IVC and an SVC component to it. And later on they were able to do it with a single caval prosthesis just in the caval position in the inferior vena cava. And again, the key to technical success of this procedure has to do a lot with procedural planning, in this case with the use of CT, to get an idea and make sure that you'll be able to approach it and how much you'll need to downsize. If the dimension is very large, at least at our institution now, they're favoring the mitral clip. Again, IVC diameter downsizing is important, as I mentioned again, and the use of IVUS is very helpful. Thank you very much.
So what do you do about anticoagulation?
So the patient was discharged on anticoagulation, and
what? Aspirin, Plavix, Coumadin?
It was warfarin and in a single antiplatelet.
Mm-hmm. Yeah, because I mean, you worry about the low flow states in these leaflets.
Absolutely.
And making sure they maintain patency. If you have RV failure, there's not a lot of pulsatile flow there to push the valves open.
Right.
Yeah, a couple other things. I think, first of all, this is all very new stuff. And I think when you deal with all very new things, things happen, such as stent migration, such as, these things are just going to occur. We've had a case where we put a direct flow in and the IVC just dilates afterward, and then you're stuck. So then that whole thing had to be retrieved. But, and so as much as the CT people want to say that they can get this right, it's really challenging. And I've even thought of just putting 2 liters in and then taking a IVUS. Just don't even do anything until you have 2 liters in, just to say what's the most it can grow. Mm-hmm. The other thing that's there is that from an imaging standpoint, I didn't see a lot of attention paid to where the hepatic veins were, and I think that that's another component. Right. We need to see whether that's open, not open, and there were a couple. I know that Adam and these guys end up spending some time doing some injections to make sure those are there. So that's another point. Yeah. And you mentioned follow-up, but I think in 2017, the other thing we really have to think about is just the pathology. So what caused this? And from your presentation, you said that the pacemaker caused it. Right. So then that begs the question: why don't we just take it out and just put a micro in? Yeah. Right. And so, or just replace that. So that's something that also should be addressed as part of the heart team evaluation. Now that we have these tools available.
All right, thank you very much.
Thank you.